What is up, guys and girls? It's Stephanie again. This time without the beard. Busy with the whole November. I don't know if it's national, just in South Africa, or if it's international. But there's a men's cancer related focus month. Awareness month, that's a word. Awareness, not focus. As always, I am on the road, so I thought I'll chat with you guys. Again, I'm doing it hands-free, like always, because safety is important. So the last couple of lessons I touched on protocol, touched on, well, not lessons, last couple of videos. I touched on protocol, I touched on triage, I touched on, somebody I know, hello. With this video, what I thought is I'll actually, I did COVID related CPR as well. If you want to see the video for that, please go check in the history or in the playlist or wherever on the YouTube channel you may find it. So I've done A, B, C, D. I've explained that. E, effect CPR. Okay, so I've explained that already. So what is F and G? F and G stands for fractures and general injuries. Alright. Now, on a conscious patient, we don't need to do E, because if the patient's conscious and awake, we don't need CPR. Then we can simply ask the patient, where are you hurt? Now, this verbal communication with the patient is actually quite important, because it allows the patient, again, some degree of a feeling of control. Remember, when the patient is like hurt to that extent, these guys are like, you know, well, these guys and girls, and you know, all of the other gender pronouns, they're usually quite scared. They're usually quite in shock. So affording them the opportunity to have some control of the situation will alleviate the shock. Now, why is it so dark? That's a bit better. So asking them, where are you hurt, will allow them to indicate where they feel they need the most help. And then you can do a proper examination on the specific area that they are speaking about. But where a patient is unconscious, and we've got to investigate, we've got to play Mr. Policeman and investigate where the actual, well, not where the actual, if there is an actual secondary injury, or what could be the cause of the unconsciousness even. So for that, we're going to start at the head. We're going to work our way down to toes. We are first going to do the center mass, the center console. No, we're not robots. The central part, the median part of the body. And the reason why we start head, neck, chest, abdomen, hips, aka pelvis, is because any injury within that framework has got a higher probability of causing either death or longer term damage to the patient on a physiological level. I mean, you would much rather treat a cranial base fracture, a head fracture, than what you would spend time treating a upper arm, aka, well, okay, let me do this, upper arm, aka humerus fracture. Because your head fracture has got a lot more risks involved than what your upper arm. There is still risks with your humerus, but not as much risks as with head. That's why we first do the central part, the center medial part, before we do the extremities. Alright, so we're going to start at the head. You're going to use gloved, flat, sliding hands. Hands is going to be flat on all of the surfaces, and you're going to be using a sliding motion. Okay, as I explained in a previous video, if you are going to be doing this, there's a risk that you might miss an injury. Same with the head. You're going to start at the front on the forehead. You're going to move your hands over and across. You're going to, without lifting the head, feel as much of the back of the head as possible. And the thing here is that we are looking for is any abnormalities, any lumps, bumps, protrusions. You can, especially because at the back of the head and you don't want to lift the head, you can look at your hands for any body fluids, blood, gray matter. Just to, sorry, I haven't had my first coffee yet. Just so you can be aware of exactly what is wrong with the patient. Now, here's the other thing that I want to mention. I said to you guys now that if the patient's unconscious, you've got to do a head-to-toe examination. But what about the situation where your patient is not mentally lacquer? They had a massive blow to the head. They've got what seems to be a concussion. They're showing signs of a concussion. They are confused. They are vomiting. They are. If I ask the patient where you're hurt, I've got, me as the treating person, has got no guarantee that this person's nervous system is actually adequate enough to relay and transmit and interpret the messages of pain in my ankle. So if your patient is not compos mentis, if your patient is not clear of mind, please do a head-to-toe examination on that either. Obviously explain to the patient you're going to do a head-to-toe just to identify any possible injuries. Okay. When you get to the back of the head, you can actually go down and you can just feel the neck. Make sure that the vertebrae in the neck, the cervical spine, which is a group of vertebrae, group of bones in the spinal column, that the scientists, the doctors classify together, called the cervical spine. All right. Feel that. You can feel that straight. There's no bumps, any dips, any ditches, anything to that extent, because that can also give you a bit of indication as to whether you can actually put the patient in the recovery position. Please remember, and I'm going to discuss this a bit further, for any patient where there's suspected head or neck or back injuries, we are not going to place the patient in the recovery position, because any twist on this vertebra could increase the risk of permanent paralysis, permanent disablement. Okay. So, head, neck. So, once you've done the neck, you're going to do the face. And what we generally do here is we do 2 bones at a time, and we can compare them. So, like with your eyebrows, you're going to take your 2 thumbs, and you are going to start in the center of the eyebrows and rub your thumbs to the outer edge. Here we are checking symmetry. So are they in line? Are they Straight, is there any dips or dings or bulges in it? I mean, if you feel the one eyebrow is going nice and straight, but the other one you can feel the bone, and okay guys, also this is the other thing, you're not feeling the eyebrow itself, you're not examining the hair. I'm going to sneeze. Sneeze gone. Okay. I hate it when it happens because it always makes my eyes tear. Luckily I'm standing in traffic. Yeah, you're not examining the hair, you're actually examining the bone underneath it. So when you did your first one, you started on the forehead. So now you can do the two eyebrows, the bones under the eyebrow. So if one is going nice and straight and the other one is doing like this funny loop, then you know that there is a very high possibility of a fracture, a broken bone under the hairy part of the eyebrow. Okay. Next, we are going to do the nose. Here we are just going to run our finger down the edge of the down the front edge of the nose, the profile of the nose. We're not going to put a lot of squeeze on there. I just want to examine whether this nose is straight, whether there's any abnormal bumps. Now, here's the thing. Please, if there is a bump, don't freak out. A lot of people, we've got one rugby player that plays for the Springboks whose nose is quite shaped differently to what everybody else's nose is. And yeah, I'm not going to name names because I don't want to get into trouble. But there's one specific frontline player whose nose looks like it might have been broken a couple of times in the past. So if the nose has got bumps, ask the patient, has your nose always had those bumps? Alright, just so you don't freak out and end up treating for nothing. Okay, next we're going to do the cheekbones, exactly the same as we did the eyebrows. Two thumbs, starting in the edge on the inside and sliding it out to the sort of the top section of the eyebrow itself. The cheekbone. Jaw, we're going to do from the top down, both sides at the same time. We're going to start right here where the jaw sort of connects to the skull. So the bottom jaw, just for those that is looking for a bit deeper thing, is called the mandible. This whole bottom jaw. The top jaw, I don't know how to pronounce it. Afrikaans is called maxilla. I don't know what the English is for it. Maxilla is Afrikaans. Okay, so that's jaw, nose. What we're also going to do in this instance, we're going to look at the eyes. I want to check the pupil reaction. So what I'm going to do is I'm going to open one eyelid of the unconscious patient. I'm going to open the other eyelid. I want to see that the pupil, which is the black part in the middle of the eye, does sort of that type of motion depending on the light outside. Okay. Then I want to do both eyes at the same time. So I'm going to open both eyelids at the same time because I want to see that the pupils are equal and reacting to light. If they are deviated, if the one is bigger than the other or reacts slower or doesn't react at all but the other one does, that could be an indication of quite a bit of different scenarios, ranging from a head injury through to drugs. There's quite a broad spectrum of stuff that can affect the the pupil reactions, okay, and the size. We're going to again look in the mouth just to double check that even if after we did CPR, we just want to double or triple check that there is no obstructions again. Maybe it came out while you were doing CPR, or maybe you didn't do CPR and you're now checking for any further obstruction. Alright, then you want to look inside and behind the ears. Now what you're going to be looking for on the inside is not a massive amount of earwax. You're looking for any fluids, any blood, any like a yellowish greyish liquid that could indicate anything, again, from brain damage through to burst eardrum. So you want to examine for that as well. Once you've checked, and then behind the ears, you are looking for any, again, lumps and bumps, but also a very big sign of a head injury is blueness behind the ears. We used to call it battle signs. I don't know if that is still a term that is being used by the newbies today, but the blueness behind the ears we call battle signs. Alright. Okay, that's all covered. From here, you want to now start moving down onto the neck. So what we're going to do is we're going to start with the windpipe, aka the trachea. So what we're going to do is we're going to use these two fingers. We're going to put it on either side of the trachea slash windpipe, and we're going to go down. What I want to check is that is this trachea straight or is it leaning towards a side? If it is leaning towards a side, if it is skewed, like let's say mine for this instance goes to my left, I don't know what it would be on your screen, your right, your left, whatever, but it's my left. That could indicate that I've got damage on my right lung. If it is leaning to my right, that could indicate I've got damage to my left lung. Especially in men, if you are examining, you are putting a tiny bit of pressure, not overly pressure. If you feel that there's any crepitus, now I'll discuss that when I get to the fractures and stuff with you guys. If there's any crackling feeling here around the Adam's apple, that could be indicated that the cartilage around the trachea is damaged, which is a big problem, because if that trachea collapses, the patient's not going to be able to breathe. Then we're going to need what we call an ET tube to get it in, if it is possible to get it in, if the cartilage and stuff isn't affecting it. Now, once we get down here on to the sort of the collarbones, I'm not going to worry about the collarbones right now. What I want to do is I want to move down to my chest. So we can't examine anywhere over the breasts, not whether you're examining a male or female, but I want to check the sternum. So what we do in this instance is from here, I stop, then I take these two fingers and I'm going to put a bit of pressure downwards, and I'm going to run it down to the bottom of the sternum, the breastbone. I'm going to run down to the bottom. I'm going to put a bit of pressure just to see whether there's any movement. Now guys, obviously if you did CPR, there is going to be a bit of movement, so don't freak out with that instance. Please just don't do this, because then you're going to be touching the breasts and you're going to get into trouble for, I don't know whether it's called sexual assault or sexual molestation or what it is called, but yeah, you'll get into trouble for that. When you get down here, we can move down onto the abdomen, And what we're going to do is we're going to actually divide the abdomen into what is it called, quadrants. And I'm going to again use these two fingers. I'm going to press quadrant 1, 2, 3, 4. And what we're looking for here is any hardness, because once the person's got internal bleeding, the abdomen will go hard. Right, so check for any hardness. And the reason why we divide it up into quadrants is that we can, if we feel top left is harder than bottom left and top right and bottom right, I need to jot that down. Oh goodness, here's a truck accident. Oh shame, man, this dude's axle broke. It's not an accident. He's carrying a crane and looks like his axle broke. The carrying truck's axle broke. Shame. It's going to be a big pain to transfer that crane over to the new truck. Shame, man. Yeah, so we're going to note it down where we felt the hardness starts, because that could assist the paramedics and the doctors to make a quicker determination as to where the possible bleeding started, because eventually the whole abdomen will go hard if the bleeding is sufficient enough, if it's bad enough. The whole abdomen will go hard. So you making that little note will tell the doctors will help the doctors to know where to start looking for the bleed. Okay, for the openness in whatever intestine is, wherever you find the start of it. Okay. Now we skip the ribs. So now I've done all of that, I can go back to the ribs. And again, I'm not going to be doing all of this stuff. What I'm going to do is I'm going to take my two hands, I'm going to place it on the side of the ribs, both sides, and I'm going to squeeze to the middle. Please don't bear hug, wrestling squeeze the daylights out of the person. You just want to put a bit of pressure to see whether you can feel any crackling, whether you can feel any movement, whether you can feel any abnormality. Give a bit of a lateral squeeze, and I can leave my steering wheel now because I am basically sitting in traffic again. Okay, if that's all fine, we're going to go down to the hips, the pelvis. Again, guys, please don't feel around the groin area, the pelvis. We are going to, again, just same as what to the ribs, put it on the side, give a bit of a squeeze, see if there's any abnormal movement on the pelvis, on the hips. We can visually have a look at the groin area, all right? But please don't make a spectacle out of it. Have a look, observe. We are checking for any wetness. We're checking for, especially, well, not especially, only in men. We are looking for a erection, because the erection could be very highly indicative. It could indicate a spinal injury. Okay, and we're not going to make a spectacle. If we see it, you can just jot it down, and then we know if there's an erection on a male. We're not going to log roll the patient because of the risk of the spinal injuries. Okay. Also, I mean, just for privacy purpose, take a blanket. I really need something to drink. Take a blanket, cover the hips / pelvis. This person's already in a bad state. They self-conscious, self-aware, got self-pity, in shock, whatever. We don't need to add to it, so let's help the dude, or the dude in this case, and just cover the hips with a blanket. can even cover the legs just to draw attention away from it. Okay. Now we're going to come back and we're going to actually do the extremities. Now we've skipped the clavicles, the collarbones. So just like what we did the eyebrows, we're going to use our two thumbs. We're going to put it on the inside part here. You can feel there's two little dots. Here at the top we've got what they call the manubrium. I don't know what the layman's term for that is, but it's the top here where the top of the sternum where your collarbones attaches. So two thumbs starting on the inside, working its way out to the shoulder. And again, you're going to check for symmetry. Are they aligned? Is there any abnormalities, any lumps, bumps, ditches, crackling? Once you get to the side closest to you, because obviously at this point you're sitting next to the patient on your knees or on your bum or whatever position you take up. I prefer on my knees because it allows me to move around without having to first get off my backside and then move around. So I just move around on my knees. It's just the logical, easier way for me. Then we're going to start with the shoulder, and with the shoulder we are going to feel as deep onto your shoulder blade, aka scapula, as possible without lifting the patient unnecessarily. And then we're going to start with the arm. Two hands, we're going to be using two of our hands, we're going to put it flat, we're going to slide it all the way down until we get to the wrist. Okay, now at the wrist, what I want you to do, I'm going to show you guys now. I promise you I'll show you in a previous video when I stop in traffic, which I didn't get to do in that video. I'm going to see if the traffic stops for long enough now for me to show you guys. We're going to look for a pulse at the wrist. The pulse at the wrist, just for information's sake, is called a radial pulse. Okay, because the two bones in the front arm, you've got your radius on the thumb side and the ulna on the what's this, pinky side. Right. It's called a radial pulse. So what you're going to do, okay, draw a line down your index finger and draw a line on the outside of the thumb. All right, line. Please don't use a pen or anything. Use your mind, imagination for those lines. And where those two lines intercept, where they cross, you should have a pulse in that area. All right. It is generally a little soft area. You can feel there's a hard part where the radius comes. It's right next to it. You should be able to feel a pulse. Now, with a pulse, we are going to check for quite a few different things, and I'll discuss the vitals in another different video as well. But we're going to feel how strong it is, how fast it is the rhythm normal. If you feel then you feel a pulse that goes to the beat of your favorite song, yeah, that's not normal. The pulse is going to go doof, doof, doof. Pulse is going to go doof, 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 doof. Not doof, 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 doof. Yeah, so if the pulse does that, there's something not lacquer with the circulation or the heartbeat. All right. Once you've done feeling the pulse here, you're going to examine the hand and the fingers. Okay, so the wrist bones is called the carpal bones. The middle of the hand bones is called the metacarpal bones, And then your fingers, same as with your toes, is called the phalanges. So I'm going to examine the hand and each set of phalanges independently. Now at the end of every set of phalanges, every finger, I want to do a circulation test as well. Alright. So what I'm going to do here is I'm going to push on the person's nail and I'm going to let it go. And within 1 second, it's going to go from that very white color back to its normal pinky color. If it is delayed, it could mean that there is a slowdown of the blood flow to the fingertips. And if it doesn't go back to pink, it could very well show you that there's no circulation to the fingertip. Now, every time you feel for pulse or do what they call a capillary refill, and you find that there's an issue with the blood flow, the pulse or the 1 second refill, what that means is before that somewhere you missed something. So please go back and re-examine the area to see if you can figure out why. Sometimes it's a medical issue, so there won't be any physical indication for you, you know, like a broken bone that can cut off circulation. So good gracious, I've been busy for 31 minutes. Okay. Then you're going to do the other arm, then you're going to go down into the legs, and you're going to do the exact same thing on the legs. The big thing with the legs is don't start too close into the groin area. You want to start like, I don't know, 20, maybe about 10-15 centimeters below the groin area, and you're going to slide your hands down the upper leg, which is called the femur, over the kneecap, which is called the patella, down along the two bones in your lower leg, which is called the tibia and fibula, and when you get to the ankle, behind the knob on the inside of the ankle, there's a soft spot. In that soft spot, there's also a pulse. This is called a tibial pulse. Alright. Then you're going to examine the feet. The ankle bones is called the tarsals. Middle of the foot is called the metatarsals, and then the phalanges, aka the toes. You're going to examine all of that, and at the toes, you can. I'm going to tell you that now. At the toes, you can also do a capillary refill. Big thing is, especially like ladies with the capillary refill on the nails. If they've got Q-Tex on, you can do the same test on the inside of the finger. You press on the inside, and it must go within 1 second go back to the white. To the normal skin color. Okay. If you find any injuries going from top to bottom, treat it accordingly, according to the protocols, according to what you got taught, so that you can tick it off your list. Alright, guys, I'm going to stop there. Because I'm already up on 34 minutes, just about, and I'm sure by now you guys are bored. As always, please like, share, subscribe to the channel. Like the video, hit the bell icon thingy. Do everything that the other YouTubers says you must do to my channel, please. Appreciate it. If you like the content, if you want to see other contents, put it in the comments. I don't know, I can even try and sing a treatment to you guys. I can't sing very well, got all the rhythm, but I can try. If you want to see that, put it in the comments. Alright, that's it from the driving safety medic, aka Stefan, aka the beardless wonder. Hopefully soon my beard will be back. The whole Movember thing for us is you're supposed to grow a moustache, but I feel naked without the beard, so my beard must grow back. But it's for a good cause. Go and Google Movember. Cancer, which is Cancer Association of South Africa, is running a whole drive this month to raise funds for research and awareness for men's related cancer, for the whole of November. So please donate to anybody you know that is doing it and is registered. I think October is breast cancer awareness, and Cancer does do something for that as well. I don't know what they do. Maybe they ask the ladies to grow their leg hair or armpit hair or something. I don't know. But yeah, please go check out Cancer, CANSA, or search Movember. Have a look about that, and then yeah, I'll check you guys on the next one, eh? Shot, bro.